We have Dr. Fijo Kuriakose, who is a consultant pediatric ophthalmology at our Eye Foundation, Kochi, and Dr. Shamika, who is a consultant cataract pediatric in neuro-ophthalmology from the Eye Foundation, Tirupur. So Dr. Fijo is going to say that refractive surgery in selected pediatric patients has a role in visual rehabilitation. And Dr. Shamika is going to say that it has no role in visual rehabilitation. So on to you, Dr. Fijo.
So good evening, everyone, and thank you, Chitra Madam, for giving me this opportunity here to talk about refractive surgery for children and its role in visual rehabilitation. So its major role is in amblyopia due to high refractive errors. So I advise parents to make their child wear glasses and wear a patch, and it sounds simple and it should be most of the time, but sometimes you have a patient like this one. Coming to another case report from Dr. Evelyn A. Pacey, and this child, she was a former premature and who had a history of ROP, and laser was done in both eyes and it resolved well. But 22 months later, this is the refractive error. So her vision is poor with glasses, but she never wore her glasses at all. And they did PRK on her at 24 months of age, and this is the laser dose. And 6 months post-op, she is now more compliant with patching, and fast forward 6 years, this is the result. Severe anisometropia causes spectacle-induced anisoconia. It causes discomfort and makes them feel off balance. Along with anisoconia, anisoconvergence also occur and impede their stereopsis and binocular vision. So children with severe bilateral high ametropia, why do they not wear glasses? Well, it's because of their neurobehavioral disorders that can cause severe tactile aversion, anxiety, autistic behavior, and ADHD. It gets worse with anything touching their face. They just refuse to wear them despite being blind without them. Next, these are those children who have poor glasses fittings, such as children with Down syndrome or other craniofacial abnormalities and microtia, which makes it difficult to wear glasses. And then children with cerebral palsy or other reason for neck weaknesses, and their glasses just ride down lower, rendering it useless. So they did a study and followed these children for 3 years and evaluated the corneal refractive and visual outcomes. They found out the corneas healed slightly faster than the adults, and it was very well tolerated with mild discomfort. These were the target doses versus the achieved dose of the PRK treatment. That is the line in the middle of the little blue area. You can see that they are close to within 1 to 2 diopters of desired treatment dose. The visual acuity also improved markedly in these patients, especially the bilateral patients. This is another patient of Dr. Pacey, a 4-year-old, when she was treated with PRK both eyes. She has a chromosomal translocation with severe cognitive disability, and she was wheelchair bound, extremely combative, and she always had to undergo a EUA for adequate evaluation of her retina. And you could see this very high refractive error that she had. And she was treated with PRK both eyes, and the treatment dose was 7.5 diopters. And so immediately after the surgery, she had a refractive error of minus 0.75. After 3 months, she comes in walking with a walker. She had never walked before in her life. She's smiling, she's not scared of anyone, and 16 years out, her refractive error is still stable, minus 1 in both eyes with clear corneas. So it was after this patient that they felt that they were doing much more than just improving vision in these children. They thought that they should assess the developmental improvements as well. So there was a study done to look at the developmental improvements after refractive surgery in a group of children with intellectual disabilities. And these were the tests. So they had to calculate the developmental quotient, which is a fraction or a percentage, calculated with the mental age in months divided by the biological age in months times 100. So a DQ of 100 would be normal. They found that in this group, the children at 6 months had improvements in all these areas of development, in communication, daily living skills, socialization, and these were all statistically significant values. Until now, any improvement in DQ was basically unheard of in developmental pediatrics. So coming to everyone's main concern, keratoplasia following PRK, even in adults, is extremely rare and has never been reported in children. This was a study on corneal stability 5+ years after pediatric keratectomy, demonstrated no topographic signs of keratoplasia or corneal haze with stable refractive error. The keratometry has also been extremely stable in this group with no progressive steepening. Significant improvements in both the myopic and hyperopic cohorts. and there was basically no complications. The patients had no corneal haze and there was no keratosis. So when we talk to families about this refractive surgery, it's important that you clearly identify the goals of the treatment, because the goal is not to get a 6/6 vision like in adults. We are just trying to prevent blinding levels of amblyopia, and it's important that the parents understand that. So when should pediatric refractive surgery should be considered? It should be considered in a small subset of children who are not responding to standard therapy. If a complication occurs, it will likely be many years in the future and treatments are available. If a complication occurs, the eye will be at least a seeing eye and worth the rehabilitative procedure. So I found this exciting study in which they found out that the visual acuity was significantly better in a group of children with severe myopic anisometropia and amblyopia following excimer when compared to a similar group of children treated with contact lenses. So to summarize, refractive surgery in children, it helps in their refractive error, visual acuity, communication skills, daily living activities, socialization skills, and there have been no serious complications long term. These were some of the parents treated by the patients with PRK by Dr. Pacey over the years and how much it really changed their families' lives. So one parent said, "You have given us such a gift. Our child who used to sit in the corner rocking back and forth now positively interacts with the family." And lastly, this one I think is the most poignant for all of us physicians and surgeons. Thank you for trying to help our child when no one else thought it was worth it because he had so many disabilities. They thought he really did not need to see very much. And that's just really like important for us to all realize that we should be able to help these children when we can and not make the decision that it's not worth it, especially when it's something very simple that takes very little time and makes such a difference. Thank you.
Thank you. Thank you, Fijo. That was a very lovely talk. On to you, Shamika.
A very good evening to all. I'm very grateful for this opportunity. And today I will be putting forth some points against refractive surgery in selective pediatric patients. As it has already been spoken, unlike adults, the aim of pediatric refractive surgery is not to attain spectacle independence, but rather to promote binocular vision by eliminating or reducing the amblyogenic refractive errors. With early surgery, while we can harness the benefit of neuroplasticity, but on the downside, we are dealing with a refractive error which is still changing and is still stabilizing, along with poor cooperation by young children. In the previous talk, we've already seen a few specific indications of pediatric refractive surgery. Let us take a closer look at some of the concerns with these indications. Starting with anisometropic amblyopia, there is no dearth of literature about the very favorable outcomes of anisometropic amblyopia, both in terms of visual acuity and stereopsis with conventional management. Additionally, newer modalities like perceptual learning and dichoptics are further promising in this regard. There are very few comparative studies till date comparing the outcomes of conventional surgeries with conventional management with refractive surgeries. However, a review of the available level 3 evidence of refractive surgeries for anisometropic amblyopia shows that while the degree of anisometropia reduced, the improvement in amblyopia was not proportional, and the functional gains were only modest when compared to conventional management. Another concern is that, as we all know, the hyperopic anisometropia is much more amblyogenic than myopic anisometropia. However, correction of hypermetropia by refractive surgery is challenging and is much limited in its application due to various concerns like inconsistent outcomes, regression, and peripheral aberrations. Thus, a majority of the proportion of anisometropic amblyopes may not be ideal candidates for refractive surgery in its current stage of evolution. Coming to bilateral high ametropia, the pros and cons of spectacles, contact lenses, and refractive surgery need to be judiciously weighed on a case-to-case basis. In this context, one of the important indications, as Dr. Fijo already described, where refractive surgery really improves the quality of life of children, is in children with neurodevelopmental and behavioral issues. However, poor patient cooperation to pre- and post-operative evaluations, increased risk with general anesthesia, and the need for multiple general anesthesias are few practical concerns limiting the use of refractive surgery in these patients as well. Coming to accommodative esotropias, while refractive surgeries can be offered to adults with accommodative esotropia, it is still not recommended for pediatric patients. And again, most accommodative esotropes being hyperopes may not be ideal candidates for refractive surgery. Now coming to some general considerations with refractive surgery in children. Patient cooperation is a practical hindrance to the widespread use of refractive surgery in young children. While on-table biometry is routinely being done for pediatric cataract surgeries, we still need some technological advancement until we can take topography maps under general anesthesia. Also, in children, it is difficult to obtain reliable topography maps preoperatively, ensure compliance to medications postoperatively, and there is a higher incidence of infections and contact lens dislodgement in the post-op period due to eye rubbing in children. Coming to some anesthesia-related concerns, apart from the general risks with anesthesia, there are problems with centration and cyclotorsion under general anesthesia. But however, since most of the modern machines are equipped with tracking systems, this can be overcome to a large extent. However, the anesthesia machine and the excimer laser cannot be considered very good friends. There may be logistical problems in bringing the anesthesia equipment in the same operating room as the excimer laser, as most setups have a separate separate refractive surgery suite. Apart from that, the excimer laser is very sensitive to temperature and humidity fluctuations in the environment, and the possibility of anesthetic gases interfering with the function of the excimer laser needs further evaluation as well. Regression is another very important concern with refractive surgery in young patients. One study of pediatric refractive surgery, PRK, in high myopia with a reasonable long-term follow-up found very high rates of regression. The rates of regression found in their study were 0.6 diopters in 1 year and were higher with higher degrees of myopia. They suggested that pediatric PRK nomograms need deliberate overcorrection to account for regression. Just like regression, we also need long-term studies to assess the risk of ectasia after pediatric surgery, and nomograms need to be adjusted accordingly. Most children do not show the subclinical signs of keratoconus at a young age, and hence it is difficult to rule out high-risk cases just like we can do in adults. The higher incidence of allergic conjunctivitis and eye rubbing further adds to this risk. Apart from this, corneal haze is found to be slightly more in children post-operatively, and they may need long-term steroids which come with their own sets of complications. Also, since the aim of refractive surgery is not spectacle independence, and we usually target emetropia at that age, most children will need some glasses, and about 1/3 of the patients will even need amblyopia therapy post-refractive surgery. Thus, it is still far from being a fairy tale ending. Also, we still lack enough long-term data till we can safely prescribe pediatric refractive surgeries to our patients. And now, enumerating the... yes, sir. This is just last 2 slides. Enumerating a few concerns with various procedures. Flap-based procedures are almost abandoned in children due to flap-related complications, which could be sight-threatening. Surface ablations are the preferred modality in children and can be considered up to moderate degrees of myopia in children with normal corneal thickness. However, regression, ectasia, and corneal haze are concerns in these procedures. For larger degrees of myopia, if the anterior chamber depth is adequate, phakic IOLs are an option. And if the anterior chamber depth is shallow, then clear lens exchange is an option. Each of these comes with their own sets of risks and complications, which need to be weighed against the potential benefits. Thus, to conclude, among the entire gamut of management of refractive surgeries, refractive errors in children, refractive surgeries will continue to have only a small role to play until we can have safe pediatric nomograms from sufficient long-term safety and efficacy data. With this, I conclude my talk and invite comments from seniors and experts.
Yes, Shamika, that was a nice talk. Dr. Shreya and Dr. Bhanumati, would you like to add something?
Both spoke very well. The only thing what I would definitely go with Shamika, especially for certain cases. But I would definitely do surgery, refractive surgery in young adults for accommodative esotropia when they are stable, because there is a lot of psychological impact. And we have done a study in our institute for 1,000 mothers, psychological impact on mother of amblyopic child. It was a impact on mother of amblyopic child. So that it's not only child is getting impact psychological impact, but mother also gets. So I agree with Dr. Figo in that developmental children, I'll definitely go for refractive surgery when it improves the development of the child.
Dr. Bhanumati?
Yeah, I see. I definitely both have plus and minus, definitely both their talks. Since we deal with children with autism, sometimes they're so violent. With high refractive error, add to that, or when we put them on these therapies, they don't wear those glasses. So to improve their concentration, we put them on many of these therapies on the, so on BTS, these children don't see properly, they're quite violent. If they tend to see better, most probably they might accept it. So which is when you cannot put them on contact lens. High refractive error with glasses, at least if you reduce it to some extent, and if they are able to see better, it might help. So especially in developmental delays, children with autism spectrum disorder, it might help. But that's what, no safety factors, GA. So you have to finish everything in one go. Do the topo.
No,
Because getting a refractive error, children are so violent. I've seen this last week, a child of 10 years.
Yes.
So those children definitely it might. This is something new I feel I might start considering.
We really want to know your opinion, Dr. Chitra ma'am.
See, I have been doing refractive surgeries for the last 26 years. And in my earlier years, I have done for extreme situations of anisometropic amblyopia and followed them up with occlusion with a fair amount of visual gains for these children. The youngest I have done is a 6-year-old, and I've done more in 11, 12, 9 and 8 and all. But it's still a small number, and somewhere along the line, more understanding of corneal biomechanics and hysteresis we stopped doing. So I really don't understand what happens to those children, because earlier we were handling more specialties. Now pediatric ophthalmology is a separate segment, and they don't send any of these patients. So I think there is a massive confusion in all our minds about the safety element of treating these very elastic corneas. So that's where we stand as of now. None of those patients of ours developed ectasia though, but it's a small group.
Ma'am, would you consider ICL, considering it's reversible, we can explant the ICL? And we're not really worried about the corneal factor.
Yes, true. But not at a very young age. You can't do that at a very young age. And but yes, maybe a little young.
Older children, young teens with this autism spectrum, so that they have some amount of functional life. We are not very worried about the cornea. Probably ICL, because explanting it would just be another GA.
Yeah, I agree. But we haven't no experience on that. So I think all of us have to go back to our home and family and dinner. Thank you so much.